This is a case demonstrating surgical resection of a lumbar intradural extramedullary schwannoma. The patient was a 56-year-old female who presented with cramping pain in the bilateral buttocks, hips, and posterior thighs. She had a long history of intermittent low back pain for a few years and was found to have lumbar spondylolisthesis on X-rays. She did not endorse any lower extremity weakness, sensory disturbance, or bowel or bladder dysfunction, and was otherwise healthy. Her family history was significant for pancreatic cancer in father and grandfather, colon cancer in mother, and she also had a brother with renal cancer. On neurological exam, she had full strength bilaterally, except for mild weakness of the right abductor digiti minimi and slightly depressed ankle reflexes. She had grossly intact sensation and normal gait. This is her preoperative imaging demonstrating the lesion of interest. Lumbar MRI shows round to ovoid intradural extramedullary lesion at L4-5, which measured approximately 28 by 13 by 15 millimeters in maximal dimension. The mass was T2 hypointense, with clearly demonstrated solid and cystic components, and was avidly contrast enhancing. At L4-5, the patient's known prior grade 2 spondylolisthesis was again visualized. The differential diagnosis included a cystic schwannoma or a myxopapillary ependymoma. Prior to surgery, the patient also underwent imaging of the entire neuroaxis, which showed no additional mass lesions of the spinal cord or nerve roots. The patient was brought to the operating room and positioned prone on a Jackson table. Neuromonitoring signals were established, and following a standard midline incision, an L3-5 laminectomy was performed. The dura was opened in the midline and tacked up using silk sutures. The nerve roots were mobilized, and the tumor was identified on the ventral aspect of the thecal sac. Next, attention was turned towards identification of proximal and distal nerve origin attachments. Interval growth of the tumor was noted intraoperatively as compared to preoperative imaging. The dura was further opened and tacked up using silk sutures to allow identification of the caudal pole of the tumor. It is important to clearly identify both the rostral and caudal poles of the tumor. The arachnoid layer was opened to allow mobilization of the nerve roots away from the tumor and allow dissection to take place directly on the tumor surface. The tumor was mobilized away from the nerve roots, and multiple fascicles splayed on the tumor surface were identified and dissected away. It is important to note that if needed, the tumor capsule may be opened and the tumor may be internally debulked. The proximal fascicle was identified, and stimulation of this fascicle did not elicit a motor response. It was divided following bipolar coagulation. This allowed further mobilization and identification of the distal fascicle. Following identification, the distal fascicle was also divided in a similar manner. The tumor was then dissected free of its remaining attachments away from the nerve roots and removed en bloc. The dura was closed in a watertight fashion using a combination of silk sutures and a synthetic dural sealant. The final tumor specimen is demonstrated here. Postoperative imaging was negative for any residual